Welcome to Work and Health. Thank you for joining us today. My name is Yusra Benjeloun, Administrative Coordinator and Project Manager with the Work Wellness and Disability Prevention Institute, and I'll be moderating the webinar today. This webinar is made possible through the support of the Community Gaming Grant Program through the BC government, as well as donations and memberships to WWDPI. We thank our program partners, Canadian Council on Rehabilitation and Work, Education Advisory Committee, and speakers who contribute to this webinar series. While we're waiting for others to join us, I'll go over a few technical points for the webinar. You should be able to hear the presentation through your computer speakers or through the conference call line if you dialed in. Please use the question box to submit any issues you may be experiencing and to ask any questions you have related to the presentation. We will collect questions submitted throughout the presentation and follow it with a Q&A based on the questions submitted. Any questions not answered in the allotted time will be answered and distributed after the event. The presentation will be recorded and posted for free on our website within a week, along with the slides. You will be emailed the direct links for all of these items when they're available. Today's presenter is Dr. Celina Dunn. Dr. Celina Dunn received her medical degree in Calgary in 1985, followed by her family practice residency in 1987. She worked in Calgary and Halifax in family practice and cancer care until 1992, when she moved to Vancouver and joined WorkSafe BC, the Workers' Compensation Board of British Columbia. Celina worked as a medical advisor for WorkSafe BC until 2000, when she became manager of medical services. Dr. Dunn is a clinical instructor with the Department of Family Practice at the University of British Columbia. She has been active in educational and outreach projects for physicians in the province of BC and involved in various evidence-based reviews at WorkSafe BC. And now I will hand it over to you, Celina.
Thank you, Yusra. It's a pleasure to be here today to speak on work and health. I think Yusra's disclosed that I am working at WorkSafe BC, and so I am paid for my time by them here. We try and mitigate any perceived or potential bias by using an evidence-informed approach and experience with injured worker population complex cases. Most of my presentations actually are developed through partnerships with UBC CPD, so we have oversight there as well, but not this presentation this time because this one was not accredited by us. Well, I want to give credit in this presentation to Dr. Terrell Fellhaber, who I hope is actually on the line with us right now. Dr. Fellhaber wrote a piece for UBC CPD called This Changed My Practice. If you Google This Changed My Practice, Dr. Terrell Fellhaber, you'll find all the main notes for this presentation today. And she was actually going to provide this presentation, was unable to. So here I am sitting in for her, and I hope she's here because she will probably be a better expert than me to help respond to questions. So that's about me. What about you? Yusra's going to start a poll. Let me know who you are so I can try and ensure there's something in this presentation for you. So I don't see the responses to that. Oh, here it is. So here's what. So most people are from workplaces, not many healthcare providers, and others interested workers and employees. Okay, well, a lot of my work has been done in relation to sort of physician education, etc. So you may see that healthcare bias here, but I'll try and make sure that I highlight areas that are interested people who don't provide healthcare directly. This was what was posted to the website about what you would learn, and this was developed with Dr. Fellhaber. And so I've kind of morphed it into my style of learning objectives, and hopefully by the end of this, you'll recognize the impact of work and worklessness on health and well-being. You'll identify some relevant medical and other bodies that have developed policies on the physician's role in helping patients stay at, return to, and remain in work. Reflect on timelines that impact work attachment, and integrate the information from this webinar alongside whatever your personal role is, whether you're an employee at a workplace, whether you represent the workplace, whether you're a healthcare provider, to consider maintaining or changing your personal or organizational behavior to help promote work and health. So the way This Changed My Practice works, it's sort of a continuing professional development award-winning little series that UBC Continuing Professional Development developed, and it's about physicians like, well, what did I do before? And what changed my practice? So what do I do now? And I'm going to run our presentation that way too. So what I did before, and just to give you a little interest, I'm putting in a few video clips. This is the start of an outrigger race, and this is what I did before to get going on this journey that we have today. And this is Dr. Feldhaber's exact words. Every day, family doctors are faced with patients who've gone off work for injury or illness of some kind. And focus groups with family doctors have shown that doctors often don't consider determining a patient's ability to work is actually within their role. They do the best they can, but they have limited information, often just a cursory understanding of what a person's job duties entail. And concerns remain that discussions about returning to work, they can cause friction in the doctor-patient relationship because the doctor is the health advocate for the individual, and often the information has to go to quasi-legal bodies or insurance companies. When should a family doctor's care actually extend beyond providing support and management for health-related issues only to management of long-term effects of worklessness? So let's run another poll here. This is copied from a systematic review by Waddell and Burton in 2006, and it says, well, what do you think? Is work good for your health? Is it hazardous to your health? Do you feel sort of 50-50 about those statements, or does it really depend on the situation? Oh, there's the results. So most people think either work is good for one's health. It's not really felt that it's hazardous. Some people are not sure, and it depends on the situation. So I don't think there's really any real wrong answer here. And let's go through the evidence and see what it shows us. Nice. So let's look at some of the research on work and health that's out there right now. Okay. The main reference that I'm using for this is this systematic review by Waddell, who was a spine surgeon who became very interested in disability when he discovered that patients he was operating on often didn't do as well as he would have thought. And he did a lot of work with Kim Burton, a therapist also in the UK. This 2006 systematic review is still relevant, but there are some updated studies being added to it. And just to start with some definitions, work doesn't just mean a paid job. Work also means other purposeful activities such as family caring, volunteer work, etc. Whereas employment implies that there is somebody working, that there's some type of employment, and there is financial remuneration involved. And so worklessness means not in any type of work, and then unemployment means that somebody's not employed, but they are wanting work and looking for work. So those are the definitions. There are some challenges with the literature. A lot of the original literature was cross-sectional in nature, which means that you're just looking at one point in time as to what the health of people is and whether or not they're at work. And that type of study really generates hypotheses that, well, maybe work does affect health, but it doesn't tend to prove the hypothesis. And of course, the results tell us information about populations, not individuals. There's not a ton of Canadian literature. But over the years, there's been more and more longitudinal data that come from population databases, so the literature is getting better. The other challenge is that there could be other factors that confound the information that we see. We know that people in the workforce are generally healthier than those outside of the workforce, and so work could be a surrogate for people's health or socioeconomic status. So the studies always try and control for these potential confounders about pre-existing health status, socioeconomic status, etc. So despite all these challenges, the evidence does tend to point in one direction. So let's have a look. If we look at cardiorespiratory health, the Waddell and Burton study showed this, but there's a couple more recent, another recent study from Duke University showing that unemployment status, multiple job losses, and even short periods without work are significant risk factors for a cardiovascular event like a heart attack. In the UK, the National Health Services review showed an association between unemployment and mortality due to a number of health conditions, and amongst those was an increased diagnosis of heart disease and high blood pressure, which is a risk factor for cardiovascular problems, with a doubled rate of hospital admissions. And this was noted that it wasn't just with the termination of a factory closure and job loss, but also during the anticipation of this. In terms of musculoskeletal musculoskeletal health, this is quite interesting. There's a very high background rate of musculoskeletal conditions like back pain, shoulder pain, etc. And most people actually do work with these conditions. Back pain is the most studied of them. And there are definitely some physical factors that can be found in the workplace for musculoskeletal injury, but the effect of those physical factors are fairly small, and it's usually for intense exposures to work. What seems to occur is that the way that musculoskeletal health is related to disability is mediated by psychosocial factors, personal factors, and workplace factors that exert a very powerful effect on what the consequences may be of the symptoms that people have in the workplace and outside of the workplace. And with mental health, in general, the studies are challenging for showing a direction of causality. We know unemployment itself causes psychological distress. We know also that work is therapeutic for people with mental health problems or with any kind of disability because it improves the management of symptoms, it improves self-esteem, it affects one's identity, it normalizes activities and participation, it improves social functioning and quality of life in general. And after unemployment, symptoms of bodily complaints, depression, and anxiety were significantly greater in the unemployed than the employed. If you look at severe mental illness, there's always been sort of the assumption that demands and stressors are necessarily a hazard for people, as opposed to the potential that potentially maybe work could be good for mental health, even for those with severe mental illness. If you look at the Waddell and Burton study, they'll say that about only 10% of people with severe mental illness are capable of working, are actually working, but about 30 to 50% are actually capable of working. Work doesn't appear to have a direct beneficial effect for severe mental illness, apart from the effects on disability for everybody. But there is a strong relationship between unemployment and psychiatric illness. If you look at suicide, there is some literature that supports both an increase in suicide attempts. There's also literature that supports an increase in suicide. The recent 2015 Lancet Psychiatry article looked at 63 countries from the WHO mortality database, including Canada, and found a relative risk of suicide associated with unemployment was elevated by about 20 to 30%. And that's separate from an economic downturn. So what's interesting is that there's also data that shows that in an economic downturn where unemployment increases, the population risk of suicide goes down, but the risk of suicide for those out of work goes up. If you look at common mental health problems and stress, which can be interrelated, there's a very strong relationship between unemployment and common mental health problems that we see. Depression and anxiety disorders, very common things that many people are at work with. As I mentioned before, unemployment causes psychological distress, and those with common mental health problems who are out of work are more likely to become chronically workless with a downward spiral. There are some psychosocial aspects of work, though, that can be associated with either lower or higher levels of stress. And the most studied seem to be the amount of control people have at work and the types of demands placed on them. In terms of substance use disorder, unemployment is a significant risk factor for substance use and subsequent development of substance use disorders. There's been reported a 2 to 6 times increase in alcohol use disorder, and unemployment also increases the risk of relapse after alcohol and drug addiction treatment. There's an increase in smoking and a gradient of cannabis use disorder that can be more problematic in men that's related to use of cannabis. Jobs insecurity itself has an adverse effect on health. And let's keep going. In terms of working hours, the literature isn't really strong one way or another. Flex time seems to improve health, but the effects seem to be somewhat weak. And the effects of work hours may be in terms of matching work hours that work for individuals, like what do you prefer yourself, what works for you in your life. And it'll be interesting to see what happens with the current generation that has a different approach to work hours and work life. In terms of just unemployment in general, there's a strong positive association between increased mortality, over 20% excess mortality with cardiovascular disease, lung cancer, and suicide. Dr. Fellhaber reported in her article these relative risks for being unemployed were 2.79 times, which is greater than diabetes, high blood pressure, smoking, obesity, and poverty. Quite stunning. There's also just a strong positive association with being unwell, and this seems to be causal for most. As mentioned before, risk for cardiovascular disease, hypertension, higher cholesterol, a susceptibility to respiratory infections, and poorer mental health and psychological well-being. And just in general, poor general health, more bodily complaints, more complaints of long-standing illness, more disability with unemployment. Unfortunately, I'm sorry, the reference got erased from this. When I send in the final copy to you, so I'll make sure it gets added. But this is a direct quote from an article about unemployed men making significantly more visits to physicians, taking more medications, and spending more days in bed sick than employed individuals did, even though the number of diagnoses in the two groups were similar. Now, the effects of unemployment just don't go to the individual, but they affect children as well. Children have risks from living in a workless household, both on their educational attainment and the likelihood that they will be workless themselves in the future. The health effects can all be modified by individual factors, the person's education, their social support and social capital, how long they've been off, and also regional factors, what are local employment rates, social support. So when you look at studies from places that have different styles of social supports, like Norway, the UK, the US, Canada, you have to take those things into consideration as well. So can unemployment ever be beneficial? So generally, unemployment has a poor effect on health, but for a minority of people, unemployment can lead to actually improved health and well-being. So I was kind of curious about that. And it's suspected that in this case, unemployment may not be a surrogate for worklessness, that there may still be some work or some other identity that people have. In terms of retirement, there's mixed results. Early results tended to show that there might actually be increased mortality with earlier retirement, but a recent study in Norway that was looking longitudinally did show that there was some association with increased mortality, but it didn't appear to be causal in nature. So you can feel comfortable about retiring if you choose to do so. So why would unemployment cause all these bad health outcomes? We know it changes people's socioeconomic status, which is related to health. People have financial worry that can lead to a stress pathway that affects blood pressure and other risk factors, can lower immunity. There's the psychosocial impact of the people around you, etc. Behaviors can change, although there is conflicting exercise there. And there seems to be a risk of one bout of unemployment leading to another. And when you look at financial stress and worry, the data from the US, which I'm not showing here, but it has been reported to show that people who are on long-term benefits make only about 50% as much as people who are employed. And this is old data on workers now that was reported at a 2008 conference, but it does show that as a population, even injured workers on compensation benefits do not make the same amount of money that people do when they are in the workplace. Most pensions and disability do not provide the same type of income as work would. And there's also an increasing literature that apart from finances, a strong sense of purpose in life really improves one's physical health, mental health, and quality of life. This is very recent work. I think I just saw it in the last month or so from a US health and retirement study looking at close to 7,000 individuals. In 2006, they were queried about their life purpose. And there was double the mortality comparing those with the lowest life purpose to those with the highest life purpose. And mortality for cardiovascular diseases and what was considered blood diseases were amongst the highest. And these are the survival curves that I pulled directly from that article. And if you look at the yellow line, you can see that the risk of dying if you have a life purpose is quite a bit higher if you're over the age of 50 in this US population than those with a low life purpose. And so this may be one of the ways in which work and employment mediate health effects. In terms of reemployment, as bad as unemployment and lack of work can be for your health, reemployment can improve your health. And what about people who are already sick and disabled? There's not a lot of data here, but there's an increasing amount of data on activity, improving health, even for people with things like metastatic cancer. And there's basically consensus that when possible, sick and disabled people should remain in work for the reasons reported here. So overall, there's a really strong case that work is a primary social determinant of health. Work-employed employment seem to be beneficial for one's physical health, one's mental health, and one's well-being in general. There are some provisos. The quality of job and the social context are important, but overall work is good for health. So if work is a social determinant of health, does your physician ask you about it? Is it part of your physician's health record? When you visit your primary health provider, are you routinely asked about your work status? So look at this, no, 100% of people say no. So that's quite interesting, but I bet a lot of the time you're asked about other behaviors like smoking and alcohol. National Academy of Medicine in the US just this year has recommended incorporating social and behavioral factors such as educational level and exercise into the physician's electronic health record. So what do we think about putting work and employment status of adults or households in which a child lives into the electronic health record and making that something that your physician thinks about and your other healthcare providers as well? So let's look at physicians and their role and policy statements and guidelines out there. And I put this clip in here because I wanted to show that sort of policy statements and guidelines. If you look at this paddler in the second to last seat, she's helping the person in the back seat steer this canoe in huge waves. And that reminded me of sort of policy statements and guidance. So the first, at least as far as I'm aware, the first medical association to come out with guidelines on the treating physician's role in helping patients return to work was the Canadian Medical Association. And I think they came out with their first policy, if I remember correctly, in 2005 and updated it in 2013. And it really says that physicians do have a role here. They recognize the importance of a patient returning to all possible functional activities as soon as possible after an injury or illness. And the treating physician's role is to diagnose and treat the illness or injury, to advise and support the patient, but look at this, to provide and communicate appropriate information to the patient and the employer, and to work closely with other involved healthcare professionals to facilitate the patient's safe and timely return to the most productive employment possible. And the CMA statement, you'll see, it expects physicians to be involved early in a stay-at-work process or a return-to-work process. And what I really love about this updated policy is it really defines the role of the physician in the traditional role, but also indicates that physicians can have this role of a return-to-work coordinator. And my feeling also is that if physicians don't wish the work of return-to-work coordinator, that it may not be considered always medical, that it's important to ensure that your patient has somebody who is advocating for them in that role and navigating that role for them. The CMA policy statement followed on the Ontario Medical Association position paper in 2009 and has really many of the same criteria in it. You'll see that the College of Family Physicians of Canada also has discussions about the physician's role in return to work. This is from the US Department of Labor. This mathematical report is very interesting and it's a number of key points. It's free online. You can find it by Googling it. This is for the US Department of Labor. The American College of Occupational Environmental Medicine also has an excellent statement in the person or physician's role in helping patients with medical conditions stay at work or return to work. It's sort of beyond the length of time I have to go through them, but this is an excellent statement also to read. And what I wanted to point out, especially because there's a number of people here who are not healthcare providers per se, but that ACOM also came out with a statement that was developed both by Canadians and American physicians in multiple specialties, a paper on preventing needless work disability by helping people stay employed. And this really speaks to all stakeholders, individuals, workplaces, healthcare providers, insurers, and probably missing other stakeholders. But they came up with 16 recommendations and 4 guidelines about adopting a disability prevention model, addressing some of the realities that are behavioral and circumstantial that can create and prolong work disability, acknowledging the contribution of motivation on outcomes and making changes to improve incentive alignment, and investing in the system and infrastructure improvements. This is really worthwhile reading, and when you go through this, you'll probably see things that you can bring back to your own workplace or your own style of work immediately. So what's the next thing that changed Dr. Fellhaber's practice is really understanding disability per se. Well, I guess this is a great change to show you here, but it's so what contributes to disability? And Dr. Jennifer Christian's an occupational medicine physician in the US who has allowed me to borrow her slides. And so this one is shamelessly stolen from her, and you may have seen it in the past. But if you look at Sam and Lou, they could have the exact same medical condition. So look at Sam, has a bad disc, has surgery, an unremarkable work history, but the supervisor never calls Sam after the surgery, figuring, oh, the physicians will handle it. Sam has coworkers that tease him or her. Sam has a disabling doctor that says, stay home until you're able to do your job, and Sam ends up with permanent disability. Look at Lou. Lou has the exact same medical condition, the exact same work history, but in this case, the supervisor keeps in touch. We need you here. In this case, coworkers are supporting Lou. In this case, you have a physician who's function and work-oriented. And transitional work is offered, adaptive equipment is put in place, and Lou gets back to work in 6 weeks. And the whole point of this is really to take you back to the fact that it's a biopsychosocial model that informs whether or not our function allows us to be active and to participate in life. And the World Health Organization in 2001 developed an international classification of function that shows this oh so well. So it obviously has a medical component. If you look at this, if you have an injury or illness, medical interventions take place. This affects your function, activity, and participation. But these are mediated heavily by environmental factors that include work and also personal factors. And so workplace interventions and social interventions can make a huge impact on this environmental aspect, and behavioral interventions can make a big impact personally as well. And so another way to look at it is that we tend to focus on these health aspects because that's sort of the tip of the iceberg that we can all see. But some of the health aspects, like work-focused care, still sit below the waterline, as do personal factors, work, and other environmental factors. And when I'm speaking with physicians, let me just go to, this is another slide shamelessly stolen from Dr. Christian, but so physicians are put in charge of this, but as you can see, the health factors are really the only ones that sit above the waterline, but doctors are sort of pressed into this because there is some desire for objective corroboration, and sometimes there's not a complete trust in the individual involved. There's also a huge faith that doctors know a lot more than we know, but often physicians don't have a lot of training in this area. It may not be considered medical, and the science is kind of weak. So it's really important for all stakeholders to understand the doctors are doing their best, but they really have become designated guessers, and they can provide important information to assist workers and workplaces, but we are not really the be-all and end-all. So if you look at those return to work factors for prolonged disability once somebody's actually already off, if we look at them in these domains, I've highlighted the ones, I've bolded the ones where I think physicians can really have a big influence, but you may see yourself here in other areas. So a work focus of physicians and healthcare providers, and for healthcare providers to be willing to communicate with the workplace. In terms of personal factors, recovery and return to work expectations are really important, and physicians can help influence those, but individuals may have other ways to be looking at those expectations as well. In terms of work, availability of suitable and safe modified work and the role of the supervisor is huge, and through physicians speaking with workplaces, they can often influence this as well. And other environmental factors, a huge factor can be if injustice is perceived with what's happened at the workplace that's put you off work, the social factors at the workplace, or actually even the compensation system that you're in. I work at WorkSafe BC. Individuals don't choose to come to us. It is the only workers' compensation system that's here in BC. And if you perceive some injustice about how the system is set up and you're in it, it's going to make a more difficult path for you. And without dealing with it, with just concentrating on the medicine and not looking at those stresses, we really can't help people through. And so here's another factor, is really understanding the urgency of intervening when somebody might be about to go off work or is already off work. Otherwise, you won't get to the finish line in time, or this canoe won't. So this is, and I'm sorry, again, the references got lost from this slide, but the blue data is WorkSafe BC data that has been reported in Spine, and the yellow data is from Dr. Christian when she was working at General Electric. And what I kind of wanted to show you here is that if you look somewhere between sort of 12 weeks here, if you look along this, I wonder if I can make this work. If you look sort of along this 50% line here, this is sort of 12 weeks here, and 16 and about 6 months here. So somewhere between that time, there's only a 50% of chance of people ever actually returning to work. And you'd think that people who are sort of sitting under the curve here are people who have catastrophic problems like spinal cord injuries and major amputations. But these individuals have the same conditions that people are at work with. And so it's really felt that the opportunity to intervene to assist people who are off work for physicians is really within that first sort of 12 to 26 weeks. And if you have the ability to interact with individuals who might be going off work, such as the workplace, the window of opportunity is even before that. How is the workplace set up? How is your management system set up, etc.? And in fact, the Waddell and Burton paper looked at what sort of helps people, but activity-based rehab, staying at work, early return to work options, and accommodated work have been shown to be therapeutic and beneficial, as well as transitional work arrangements with improved communication. And some evidence of this can be seen sort of south of the border here. There's a project that was done that was very well studied. If you look at the Centers of Occupational Health Excellence Project in Washington State, they have healthcare providers who might provide primary care, physicians, nurse practitioners, chiropractors, etc., who can sign up in the first 12 weeks, can sign up to be part of this project, and individuals can choose to see these primary healthcare providers or not. And these primary healthcare providers have agreed to get extra education in how you can approach disability to help patients. And the 4 things that they're asked to do is to act in a timely way, to provide a activity prescription, to make contact with an employer, and they have access to an occupational medicine specialist and a care coordinator. And this has improved patient satisfaction, physician remuneration, lowered disability, improved recovery. This is one of those cake and eat it too outcomes that has occurred. And the final area of what changed Dr. Fallhaber's practice that she talks about is really the value of collaboration in patient-centered care. And this is what I've already spoken to a little bit about already, but the importance of speaking together and communication is one of the things that we find huge often at WorkSafe BC is getting all parties together to just speak and get to be on the same page. This is from my colleague, Dr. Paul Farnhan, who has done a lot of occupational medicine work. And really what the workplace has seen in the past is it was a physician role to determine whether or not somebody could be at work. And it was a physician-patient conversation. And really, the workplace was almost barred from that. And they just either got a clearance note or not, and they were kind of sidelined. And really what the new reality that we're trying to create now is that workers and workplaces would discuss options. You know, in many cases, if you're sick with the flu or something like that, you work it out with your workplace when you're coming back to work. You don't need a note from your physician to do that. And with many, many conditions, these things can be worked out. And a healthcare provider can be used in sort of their best guesser role to assist with whatever expert information we have on what's too unsafe to even try and what are the capabilities that we can talk about. And insurance carriers like WorkSafe BC, they can be a trusted party that has information from all of these areas to promote communication. And that's sort of what we're trying to move towards now. So what does Dr. Fallhaber do now that makes it all work? And I want to show you this aha moment with these paddles in the air. And why? Because look what they're doing. They've caught the wave. So in the words of Dr. Fallhaber from her article, why should physicians encourage early and ultimate return to work whenever they can? In a nutshell, because it's usually in the patient's best interest to remain in the workforce. Clinicians should be encouraged to assume a safe and sustainable return to productive activity will result in the best health benefit to their patient rather than assuming that absence from work will enhance outcomes. Here's a booklet that she mentions in her article from the UK. This is called Advising, well, I forget what the title is now, it's screened up on me, but it is an advice for health professionals, and you can find it free online. And there's the key points that it makes. Work is generally good for physical and mental health. It's therapeutic and important part of rehabilitation. But long periods out of work are harmful for physical and mental health. That 2/3 of sickness, absence, long-term incapacity, and ill health retirement are due to mild and moderate common health problems, so much of that should be preventable. And remembering for healthcare providers that advice to stay off work is a major clinical intervention that can have potentially serious long-term consequences. We often think of prescriptions, and the advice that we give with medications. When we give prescribed advice to stay off work, there are consequences, and it's kind of like a black box warning needs to go with it. So it should be prescribed carefully. Common health problems can often be accommodated at work, and that planning and supporting return to work are important parts of your role as a healthcare provider. I wanted to point out as well that, again, down south of us, the Washington State Department of Labor and Industries, which is kind of like the compensation system here, they have it's marked as out of date now because I think the update date for this is meant to be 2015. It was written in 2012, and they generally update their materials every 3 years. But it still has some great information in it. And this is one of the most helpful desk references that you may find, with a lot of information about why physicians would want to do this work and how you can actually do it. So if you're a physician out there, you may find this helpful. And if you're not a physician, it may help you actually to have a look at what physicians could help you with by looking at, how much does a can of paint weigh, etc. So the key points for physicians are really keeping patients off work increases the risk of long-term disability, really only to prescribe work absence when it's absolutely required. The physicians sometimes wear two hats, the physician hat and the return to work specialist hat. And physicians can provide helpful information, and that managing staying at work, returning to work, and remaining at work is a collaborative effort. It's mostly mediated by workers and workplaces, but physicians do have a role here. And the key points from the Waddell and Burton review are that good work improves income, it provides identity, a place in society, and it promotes good health. And that worklessness worsens physical, psychological, and mental health, and increases poverty and mortality. And that reemployment improves self-esteem, mental and physical health, and increases income. And that the benefits apply not only to the individual, but they apply to families and they apply to society in general. So when their health condition permits, sick and disabled people should remain in or re-enter work as soon as possible, because it's therapeutic, leads to better health outcomes, and minimizes the harmful physical, mental, and social effects of long-term sickness absence. So I actually finished a bit early. When I timed myself, I was finishing later, so I must have spoken quickly, but I can take any questions now, Yusra, if any have come up in the chat.
Thank you so much, Celina. Yes, we have a few questions already, and we'll start our Q&A session immediately. So to our audience, if you have any more questions, please insert them in the question box. So let's start with the first question. In your opinion, Celina, if there are no financial stresses, how would unemployment impact an individual?
If there were no financial stressors?
Correct.
Well, I think that some of the data that I was showing before, sort of on the identity that individuals have in the workplace, on the fact that it's a social environment for people, and especially the sense of purpose, the literature that's coming out on that, these seem to be huge mediating factors of why work makes a difference for people, and why being off work can be problematic for people, apart from finances and the stress about finances. And I think that's one of the reasons that the retirement literature is a little bit mixed, because a number of people retire and they have specific goals. I'm sure that you've seen people around you who are retired seem to be busier than they were when they had paid employment. They're busy volunteering, in other activities, and they do find a sense of purpose in life. And you'll see other individuals, and retirement has been really quite miserable for them. Their identity has been completely wrapped up in work, and if they aren't able to retain an attachment to the workplace, their mental health declines and their physical health declines. So I think it's mediated by some of those factors, and that's what the consensus seems to be. And I think there's some literature to suggest that that probably is the case.
Thank you for your explanation. Moving on to the second question, and I'll just remind our attendees and later on viewers that CMA is the acronym for Canadian Medical Association. So are those CMA policies mandatory, and are they adopted by physicians?
The Canadian Medical Association is it's an association that not all physicians may actually belong to. Membership is there to sort of support physicians, and they'll also often come out with sort of position papers. But you know, where I work at WorkSafe BC, when we have a policy, it means we need to follow it. We're required to follow it. The policies that the Canadian Medical Association would put out, and I might be proven wrong by this, but my understanding is that this is what they feel the membership should adopt, that you know, this should be our common understanding. And so yes, we should be adopting it, but not all physicians will always be aware of all the policy statements out there. And the challenge again for physicians is that even if there's a policy statement out there, actually putting it into practice can be difficult. So when you look at, if you looked at that Mathematica paper, if you looked at the ACOM guideline on preventing needless disability, you'd find in sort of those 16 points are things like providing better curriculum and education for physicians on how they can integrate this role of helping patients return to work alongside their role that they get most of their training in medical practice, how they can safely have a conversation with the workplace, with privacy issues and the concern around divided loyalties. You can see why physicians might be concerned. Where does the science start and where does it end? What am I doing that's helpful in terms of collaborating and communicating and et cetera? So I think that while physicians generally agree whenever I speak with physicians that work is important for patients' health, and there's a number of physicians who do this work all the time, it is difficult to incorporate every day. And I think if you're out there looking at what physicians do, the other thing to remember is that we often only see at workplaces, in insurers, etc., areas where disability has become prolonged and it's challenging, communication is challenging. The other ones that are handled so expertly by physicians, we don't tend to see because we've promoted workers in workplaces discussing it and people are getting back to work. And so what we don't see is what's working well. And to give you an example with WorkSafe BC statistics, about 80% of claims, they just fly through our system very easily. And so we know in there that we have injured workers who are resilient and have personal coping methods and beliefs that are helping them out. We know that means there are workplaces that are accommodating people who work there, and we know that means that there are healthcare providers that have a work focus to their care alongside the medicine. So for about 80% of cases, that happens. So it's in these 20% of cases where there's prolonged disability that these are the areas where we need to really sort of develop and enhance these skills. But it's hard work. I hope I've answered that.
Yes, there is so much to do indeed, and I believe you touched base on that. But the next question was, is there a follow-up on the results of these CMA policies when they were implemented and to evaluate if they were successful?
Oh, I see. I don't think that there's an evaluation component that goes along with the policy. I think it's a consensus statement. But you know, if you send me that, Yusra, after I'll inquire. The thing that we know makes a difference is that having leadership does help change behavior. It does, policies help governments, they help agencies like WorkSafe BC, they help individual physicians, they design forward-thinking changes. So what changes have been made since this policy came out? Has there been an exact evaluation of it? I don't think so, but I'll ask. But I know that it is part of sort of the leadership that is helping us to move from a place that we were. And I can tell you, even I've been at the board now at WorkSafe BC for 26 years, and the changes that I've seen in how we do our work, how workplaces have changed, how we see a number of physicians taking on this role, you do see it sort of anecdotally, but I'm not sure if there's a real evaluation that I can point you to, but I'd be happy to look for it.
Thank you so much. We would really appreciate it. So, following the next question, would you be able to sort of summarize the factors that effectively contribute to return to work? I believe you've mentioned the importance of employer support as well as physicians' interventions as well through promoting functionality and timely rehabilitation.
I think what I was trying to get at you mean when somebody's already disabled, what promotes return to work?
Correct.
We know that activity-based treatment helps. We know that a work focus of healthcare providers helps. We know that workplaces that are accommodating help. We know that the direct relationship that an individual has with their supervisor mediates return. There was a really interesting study that was done with a Canadian bank where there was, I think, maybe a half day or a day spent with managers describing what it's like, the impact for individuals being off work, and how you could actually safely phone somebody that works for you and express your concern and interest. And I think that reduced the rate of disability by about 50% just by having a genuine call. These things have to be genuine in nature. They can't just be, we're doing it to tick a checkbox. That improves work, and there's been a lot of studies going back to Boeing showing that the direct relationship somebody has with one supervisor is a huge factor as to whether or not somebody will book off work when they have a health condition or not. So it really is these biopsychosocial factors, and so in the healthcare domain, let me just go back to that slide again. I kind of think this is maybe a good way to look at it. That these are, so those are things that we know help, and these are risk factors for prolonged work disability once somebody is off. So, so the things that we know for physicians, for example, screen for substance use disorder, screen for a psychiatric disorder, be willing to talk with the workplace. And because we know that personal coping mechanisms and a perception of injustice, the behavioral interventions can help with that, helping create recovery and return to work expectations, how you manage your workplace, how you train your supervisor, how supervisors interact with people who work with them once they're off, and then really addressing the stresses that can occur for people based on the environmental situation they're in, whether they have a claim, whether something may have happened to them, for example. I mean, a little example of that is when we see sometimes individuals who have a workplace injury and they really feel that there was something that was unsafe at the workplace. We have the benefit at WorkSafe BC of having prevention aligned with us, and we can have an officer go out to check safety at the workplace. It goes a long way towards feeling that something that happened to you might not happen for somebody else in the future. I hope I've answered that question.
Yes, thank you so much, Celina. And lastly, what are the next steps to make this research field advance? What's lacking? What are the barriers, in your opinion?
You know, I'm most familiar with the barriers for physicians, so I'll comment on that first. But I think that for physicians, we really need curriculum. Physicians need support and management. The way that patient encounters work right now don't lend themselves that well to communication. Workplaces understanding what physicians can actually speak to and what is not really medical in nature. We'll often find that physicians get forms asking people whether or not they can lift 5, 10, or 15 pounds. And, physicians usually just sit with their patient and they say, well, can you lift 5, 10, or 15 pounds? Because we don't have a way in our office to measure that. So unless there was a reason to not trust your employee, those are communications that workplaces and people who work there can have together. I think ideally, if individuals and their workplaces could come up with return to work plans and just go to the physician to look at, is there something that's so unsafe here? We've already agreed to this. Is it okay? Or is there some activity here we should restrict? For example, somebody's on a medication that makes it unsafe for them to drive heavy equipment. That would go a long way. I think as we start to integrate social determinants of health into the electronic health record, and physicians use their health record to query things, physicians could do a query on how many of their patients are actually at risk because they're not attached to the workplace, children at risk. I also think that one thing that is missing a little bit from the whole situation, I know at WorkSafe we see a lot of work is being done with workplaces right now, and we see workplaces stepping up more and more into trying to integrate what the risks are and what they can do to provide accommodated work, to have real genuine conversations with workers. Often it's easier to do these technical things like make accommodations available than to look at the trickier things like the behaviors and the interpersonal interactions. But behaviors and interpersonal interactions are sort of the stuff of life. And unless we can sort of start to address it and understand that workplaces have their own cultures, etc., and that they can be sort of positive or negative cultures, it will be hard for just the technical things alone to make a difference. I do think it would be really important for the public in general to understand how important work is. I think for many individuals, they kind of get it, but I think that there's been a real focus on physicians and workplaces, but there hasn't been a sort of, we have public health approaches to reducing smoking. We have Mothers Against Drunk Driving, speaking to individuals. And I don't know if individuals really understand the harm that can come from prolonged work disability to themselves and to their families. I think that understanding that being off work and collecting benefits, while it may really be necessary and it's an important social safety net, can also be a risk. And so doing what you can to remove yourself from those benefits and get back into the workforce and workplace can be beneficial. So those are things that I think are sort of next steps.
Thank you so much, Celina, for your explanation and answers. Did you want to add anything to the webinar before we come to an end?
No, I will. I do see that there's some references missing with some of the slides, and Yusra says she'll be publishing them in a week or so. So I'll make sure that all the references are attached, and then I'll add a slide of all of the references as well. Thanks for participating.
Thank you so much, Celina, for making the time to be with us today and for this compelling webinar. We truly value you sharing the impacts of worklessness on health. Thank you for bringing several alarming effects that worklessness has to our attention, such as increased mortality as well as a series of health conditions. Also, thank you for showing that family doctors can help avoiding these negative impacts for a safer and more sustainable return to work as well. To our audience, a special thank you for joining us.